Good morning, everyone, and welcome. It's wonderful to see all of you here. And I think that Dr. Alvin Tierstein would be proud and happy. He is the giant on whose shoulders we stand today. And nothing would have made him happier than to see that the support group continues with its mission to disseminate knowledge, continue its research, to educate patients, and to have advocacy for and by the patients, and also to see that we continue with these conferences that honor him, but more importantly, are there for the care and management of our patients. And in that spirit, then, I would like to just add a little bit more to what Adam has said for specific diseases or complications of sarcoidosis for which we do have therapies, or we borrow therapies from other diseases that are, can be handled similarly. And I just wanted to talk to you briefly about three of these manifestations of sarcoidosis. May I have the? Great. So wanted to talk to you about these comorbidities that are important, and that is that of cardiac sarcoidosis, pulmonary hypertension, and a little bit on neurosarcoidosis. As you have heard from Adam already, this is a multisystemic disease that can affect all and many organs, sometimes simultaneously, sometimes sequentially, sometimes it pops up in one organ, and we have to discover that it's sarcoidosis by looking in other organs that were not symptomatic at that time. So the issue of cardiac sarcoidosis is one that we have to look for in every single patient that has sarcoidosis. In some patients, this is the predominant manifestation of their disease. We first define it as any involvement of the heart in patients who have sarcoidosis, be it electrical, your EKG is abnormal, or you have symptoms that relate to the heart. We do not need to biopsy your heart to establish a diagnosis of cardiac sarcoidosis in the proper setting. Fortunately, we have many tests that we can do in order to make this diagnosis. The incidence and prevalence of the cardiac sarcoidosis is not known. It has been estimated to be something about 25% of the patients with sarcoidosis. However, it's only clinically evident in less than 10% of the patients, usually 5 to 7%. But it may cause death, and that's why it's important for us to look for it in all our patients and to do what has to be done to prevent the morbidity of this disease from continuing. It is certainly a major problem in Japan, where it is frequently seen in patients there. And for some unknown reason, such as maybe genetically predisposition, it is a more common finding in females than it is in male in Japan. Okay. If the granulomas are strategically placed in certain parts of the heart, then you're going to see some of the symptoms manifested. This is a heart in cross-section cut up. It is made up of the right side of the heart and the left side of the heart. There are 4 chambers to the heart, the atria and the ventricle, both the right-sided atrium, the right-sided ventricle, the left-sided atrium, and the left-sided ventricle. The right side of the heart receives the blood from the body, pumps it into the lungs to get purified. So then it comes back into the left side of the heart, and from there, it's being pumped to the rest of the body with purified blood coming from the lungs. If you have any granulomatous inflammation of the heart, it can affect you adversely. This is the normal distribution or discharge of an impulse. It starts here in the right atrium, right there, and then discharges along that middle wall called the septum and into the right ventricle or the left ventricle. And you can see that these fibers are nerve fibers or electrical conduction pathways where the discharge is happening or when the impulse is being generated. The granulomas, again, here they are, these clusters of little cells, and then they can be in that area. If they're in the septum, they can cause some different patterns that are going to be abnormal on your EKG or on your presentation. Some patients are totally asymptomatic with involvement of the heart, but other patients may have rhythm disturbances such as palpitations. They can be lightheaded, they can have fainting or almost fainting, and some of them can be the presentation of this disease. So as you heard before, you can develop chest pain, you can be fatigued from this, you can have shortness of breath because the heart is not pumping effectively, and you can develop even heart attacks and murmurs and gallops and things. How do we make a diagnosis of cardiac sarcoidosis? First, the EKG is one of the most important tools that we have, but we have also the echocardiograms, and most of you have undergone an echocardiogram at one time or another. And this is an instrument or a device that picks up sound waves from your heart and then translate it into things that we can interpret as good contractility of the heart or some other abnormalities in it. Other tests that you may undergo for the diagnosis of cardiac sarcoidosis include various radionucleotides or isotopes or nuclear medicine tests that your doctors may request. And certainly the most important one, or the one that has been detected to be most sensitive, is the PET scan. And a number of you probably have undergone a PET scan because that helps us pick up acute inflammation in the heart, and it also tells us a little bit about scars that may form in the heart. Okay. We also do the MRI. So some of these are complementary. You may be asked to do more than one test to try to determine whether the involvement is in the heart. Okay. And this is an MRI that tells us that there are areas here that we call hyperenhancement or delayed enhancement, and it because we have learned a little bit about this, we know that this means that there is involvement of the heart by sarcoidosis. Okay. And this is just a PET scan that when we get it back, it looks very nice and it lights up, and the inflammation is right here in this particular heart. And so that helps us to manage the patients appropriately and to start their therapy or to stratify them. And we send you then for a special test called an electrophysiologic study, where we look at your rhythm and see if we can evoke abnormal rhythms in you, and that helps us determine who needs a defibrillator to be placed to prevent any of these arrhythmias, and who needs therapy, and who can be followed prospectively. Okay. We are still learning a lot about how best to treat patients with cardiac sarcoidosis. But what we do know is that sometimes we need more than just one therapeutic approach to the patient with cardiac sarcoidosis. We may need steroids, we may need other agents to go along at the same time that we put a pacemaker or we put a defibrillator, something that is going to shock the heart in the event that the heart has a bad rhythm. And so these are all the important things that we do here. Okay. How do we treat it? As I said before, antiarrhythmics for some, pacemaker for others, and some of them require defibrillators. And the important thing is that cardiac sarcoidosis can be detected, should be detected, can be managed, can be treated, and we have changed the prognosis of cardiac involvement for sarcoidosis. If you look back 50, 70 years ago, the prognosis was worse than the prognosis currently is, because I think that the survival of the patients is much greater. We have truly changed the way cardiac sarcoidosis behaves in our patients, particularly by the placements of the AICD, which have been very life-saving. Okay. The second comorbidity or manifestation of disease that I wanted to briefly touch upon is that of pulmonary hypertension, high pressure in the pulmonary circulation. Okay. When you go to your doctor and you have your blood pressure checked, they get the systemic blood pressure. And that can be done by a sphygmomanometer, by just that blood pressure cuff. We cannot measure the pressure in the lungs the same way as we do the systemic pressure. And that's why we have to either think about the possibility of pulmonary hypertension and then do some of the special tests that we have to do to establish the diagnosis and to then intervene if we have to in patients with pulmonary hypertension. Again, the mechanisms of pulmonary hypertension in patients with sarcoidosis are varied. And here we have one where the granulomas are in the vessels of the lung, and that's what's causing the pulmonary hypertension in this particular patient. There are other mechanisms by which we get pulmonary hypertension. If your oxygen level is very low, the normal reaction of your pulmonary vessels is to constrict, to get tight, and that can make the blood flow through those vessels very difficult, and this can then lead to pulmonary hypertension. You can have fibrosis that then closes off some of the vessels or involves some of the vessels, and we saw the granulomatous involvement. You can also have mechanical obstruction where the vessel is kinked because of the fibrosis of the granulomas or the surrounding tissue. Is there a genetic predisposition for the development of pulmonary hypertension? Perhaps there is, and studies are being conducted in this particular area. So when to suspect it and when to treat it and which patient goes for evaluation for pulmonary hypertension, we still are trying to figure out. There was a study that we conducted here where we took 106 patients, and some of them had pulmonary hypertension and some did not. We then looked back at their studies to try to see which patients could we predict we're going to have pulmonary hypertension. And at the end, we found certain things in your breathing test that help us to determine that you do have pulmonary hypertension or you do have a high risk of it. And we also looked at echoes and we looked at cardiac catheterization. And together we concluded certain things on that. We looked at your breathing test, that is very important, and you get breathing tests frequently whenever you go to your doctors. And we know that if your small airways are very low, that may be an indication to suspect that patient of having pulmonary hypertension. But nothing that we have discovered there is set in firm. So these are things that kind of hint at what you should do, and we need to continue to have these studies going on. So the echo is very important, and it does help to make us suspect the patient, but the cardiac catheterization is the gold standard to confirm it, and we do that before we decide to start a patient on therapy for pulmonary hypertension. Okay. And what is the treatment that is available? Certainly for those who have very low oxygen level, just replenishing their oxygen and giving oxygen supplementation has a role to play. There are certain patients that would benefit from a little corticosteroids in those cases. It's very difficult to determine who that patient is at time. And then we know that we have vasodilator therapy. This works very well for patients with primary or idiopathic pulmonary hypertension, but studies are being conducted in patients who have sarcoidosis to try to determine if the same agents can help the patients with secondary pulmonary hypertension due to sarcoidosis. And certainly some of these agents may be the calcium channel blockers, nebulized vasodilators, agents that open up the vessels, and there are now a plethora. There are many, many agents that are being trialed in sarcoidosis as well as in primary pulmonary hypertension. So maybe some of you are already on some of these medications for the treatment of this. Okay, so therapies are becoming available for the management of pulmonary hypertension in our patients. And so just briefly touch upon neurosarcoidosis, because that, again, is another one of the comorbidities and complicating manifestation. And it affects about 10% of our patients, more than 50% of with patients who develop neurosarcoidosis do so with these signs within 2 years of their diagnosis. And to get neurosarcoidosis alone is very rare. You usually have it in the setting of sarcoidosis and other manifestations. Okay. So the cranial nerves, those nerves that innervate your eyes, your mouth, your sense of taste and smell and everything else, are often involved. You've seen patients with a Bell's palsy where you can develop that kind of involvement. They can be brain lesions. They can be diseases that, granulomas that affect the coating of the brain called the meninges, and that's meningeal disease. And then the peripheral nerves can be involved also by sarcoidosis. And here are some examples of MRI, which is the best technique that we have of involvement by sarcoidosis here. Okay. So the symptoms, as you heard before from Dr. Morgenthau, can be varied and depending on where these granulomatous inflammation are. And again, diagnosis, MRI is certainly by far, with and without contrast, is one of the most important tools that we have in establishing this diagnosis. And then other things. Brain biopsy, we almost never do. Often this is a diagnosis where you did the brain biopsy and discovered it was granulomatous disease because you thought you were dealing with a brain tumor. And so we back into that diagnosis rather than use the brain thing. And the treatment for this disease, again, is the same treatment for granulomatous inflammation in other parts of your body. So these is essentially all. The three comorbidities that I wanted to touch. I didn't touch upon the other organs that can get involved, such as your bones or your kidneys and skin. We can leave that for another conference.